Extensor tendon injuries. We will divide the lecture into different headlines. First, we will discuss the anatomy. Second, we will discuss the zone of injury. Third, we will discuss the zones of thumb injuries. Then we will discuss repair techniques, and then we will outline the compartments. So extensor tendon, regarding the anatomy, it runs over the dorsal of MCP joint and held in place by sagittal bands. And so the central location of extensor tendon at MCP is held by sagittal bands. Sagittal bands are inserted to volar plate and they are disrupted during the punching injury. You can see these patients in the ER with sublux extensor tendon during flexion and extension of the metacarpophalangeal joints. At MCP, the extensor tendon joins the extensor hood. The extensor hood has three slips. First is the central slip and the two lateral slips. The central slip, basically it inserts at the dorsal aspect of the middle phalanx and extends the proximal interphalangeal joint. Lateral bands are lateral to the central slip and have contribution from the interossea and the lumbricals. The lateral bands are around the proximal interphalangeal joint before coming together distally and insert on the dorsal aspect of the base of the distal phalanx. There is a triangular ligament which connects the two lateral bands as they converge and inserts on the distal phalanx. These triangular ligaments prevent the subluxation of the tendon volarly. Inversely, the transverse retinacular ligament originates at the edge of flexor tendon sheath at proximal interphalangeal joint and inserts on the lateral portion of the lateral bands and prevent the dorsal migration of the lateral bands. Regarding zones of injury, zone 1 is a disruption at the level of proximal interphalangeal joint. Most common clinical entity with this injury is mallet finger. They can be classified into bony or tendinous, can be caused by laceration or direct trauma, in which the DIP is forced to flexion. For less than 3 months of injury and non-displaced bony injuries can be treated with proximal distal interphalangeal joint in full extension and the proximal interphalangeal joint free for 6 to 8 weeks. Large bony fragments, like more than 50% or more than 2 mm of step off or sublux distal interphalangeal joint would need operative intervention. More than 3 months old mallet injuries would need tendon reconstructions. Remember that the results of these reconstructions, still the patient will have extensor lag and the consent should be signed regarding this. Zone 2 injuries are the laceration at the middle phalanx and these can commonly need repair. Zone 3 are at the level of the proximal interphalangeal joint. These patients with zone 3 injuries can lead to traumatic boutonniere deformity. How to detect central sept injuries prior to development of boutonniere deformity? This is called Elson Test. The proximal interphalangeal joint is bent 90 degrees at the edge of the table. Patient is then asked to extend the proximal interphalangeal joint. If the central slip is disrupted, the extensor force will travel around the lateral bands and cause the extension force at the distal interphalangeal joint. In patients who have central slip disrupted, the proximal interphalangeal joint extension will be weak and the DIP will become more stiffer as potentially more forces are traveling through the lateral bands. Remember that normally the force travels through the central slip and the lateral bands are lax and you can easily flex the distal interphalangeal joint. So Elson test is positive when when the PIP is flexed at 90 degrees and extension at the PIP is weak or there is tightness at the distal interphalangeal joint, and this means the central slip has disrupted. Zone 3 are the injuries at the proximal interphalangeal joint. Basically, they are volar dislocation associated with lacerations. Closed injuries can be treated conservatively by splintage, and open injuries would need repair. Chronic will cause boutonniere deformity. Zone 4 injuries are at the proximal phalanx. Zone 5 are the injuries located at the MCP joint. Two entities should be remembered at the level of MCP joint. First is sagittal band disruption, and the other is fight bite. Sagittal band disruption, also called boxer knuckle. The most common boxer knuckle entity will come with long fingers, and the most common band rupture is radial sagittal band. The treatment for the boxer knuckle, if it's less than 4 to 6 weeks, is MCP to be held in extension with a splintage. The chronic will need a sagittal band reconstruction. Regarding the fight bite, the metacarpophalangeal wound is an entity and has problems. Normally, the extensor tendon injuries can happen with this, plus there is inoculation of bacteria into the MCP joint. What happens is that basically when the punch is elicited, the MCP is held in flexion, but the bacteria inoculum is entrapped inside when the MCP joint is extended again. These patients would definitely need debridement and antibiotics. Commonest bacteria for fight bite is Streptococcus viridans, and one of the most commonly tested is Echinella cordans. Also, gram-negative bacteria can also cause these infections. Type 6 are the level at the metacarpal joints. Type 7 are the injuries of the extensor tendon at the level of carpal bones. Here, the repair will not only be for the extensor tendon, but also the extensor retinaculum will have to be repaired to avoid bowstringing. Type 8 are the proximal to the carpal bone at the muscle bellies. Regarding the repair technique, less than 50% extensor tendon injury, and if the tendon glides smoothly, should be observed. If more than 50% tendon injury, it should be repaired. 4 to 6 strands of sutures should be used of adequate strength to allow early motion. When is the repair of tendons weakest? It is the second week or 6 to 12 days. Chronic tears like extensor pollicis longus injury after closed Cooley's fracture or distal radius fracture can be treated by transfer of extensor insidis proprius. So exam scenario, a patient will be coming after post-cast removal for a distal radius Cooley's fracture which is undisplaced, is unable to extend the thumb. So this is probably extensor pollicis longus tear, and the treatment will be EIP transfer. Large segmental extensor tendon tears, autograft or allograft can be done. Regarding the compartments in the extensor tendons, they are named into 6 different compartments from radial to ulnar side. First compartment has extensor pollicis brevis and abductor pollicis longus. It's commonly involved in de Quervain disease. Second compartment is extensor carpi radialis longus and extensor carpi radialis brevis, and it is involved in intersection syndrome. Intersection syndrome is basically intersection between the compartment 1 tendon to the compartment 2 tendons. Compartment number 3 is extensor pollicis longus and is commonly disrupted in non-displaced Cooley's fractures which are treated non-operatively. Type 4 compartment is extensor insidis proprius and extensor regionum communis. Fourth compartment is also approach for the dorsal wrist approach for arthrodesis of the wrist joint. The compartment 5 is extensor digiti minimi. It's mostly involved in Vaughan-Jackson syndrome. Vaughan-Jackson syndrome is ulnar to radial rupture of the extensor tendon, commonly seen with progressive deformity of rheumatoid arthritis. Compartment 6, is the extensor carpi ulnaris and is commonly involved in snapping ECU syndrome. Also know that ECU subsheath is a part of TFCC, triangular fibrocartilage complex.